السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا. Today we will have a special presentation with a special person. He's a colleague of us, Dr. Ahmed Alomrani. He's a well-known interventional pediatric cardiologist and adult congenital heart disease. Dr. Ahmed Alomrani has special interest in small babies to close their PDA, and he has a good experience in this field. So we ask him to share with us all this knowledge and information. So we thank him to accepting our invitations. And today is his night to tell us about all the information about this. In fact, it looks like a new for us, and it's done a lot of places, but Dr. Ahmed will tell us more and more. Dr. Ahmed Alomrani is a senior consultant of pediatric cardiology in King Abdulaziz Medical City, Riyadh, King Abdulaziz Heart Centers, and he most welcome for us, and we thank him for accepting our invitations. Although all of you are most welcome, and shortly after the end of the presentation, we'll have open discussions. The people who want to put their questions, they can leave it in the question area, and if they want to speak directly, they are most welcome. It's your area, and you are most welcome. Thank you, Dr. Ahmed, and you're most welcome.
Very much, Dr. Umar and Dr. Ahmed Zahrani, for giving me this chance, and I should congratulate you on being a leader on YouTube and Zooms, and I think you beat a lot of us who try to disseminate information to people. What I'd like to share with you, I'm sharing the screen now. I don't know if you have it. So, what is going on with the interventional group? It's actually becoming a new uncharted territory for the past. Before 5 years ago, it was sort of like unheard of, and was done on sort of like on a life-saving matter. But now it's been hot. It's been approved. It has an approved FDA device and a procedure that's been recognized by a sophisticated tertiary center around the world. So in brief, first of all, talking about the PDA. It's basically a structure that connects proximal descending aorta to the pulmonary artery. We know that it's essential to fetal life. The patency of after a few weeks of life considered to be abnormal, and in normal development, the distal portion of the left sixth arch. So we went over the definition, and going back to fetal physiology, it counts about 65%. Of the fetal cardiac output passes through this structure in the fetus. And usually it's just about less than 5% will go to the lung. The media of the ductus arteriosus is different. It's composed of longitudinally and spirally arranged layer of smooth muscle. That's different from the pulmonary and aortic media. The intima of the ductus arteriosus is thickened and irregular. And when the smooth muscle fibers within the media constricts after birth, result in thickening and luminal arbitration and shortening of the ductus. And later on, which will result in the fibrous band as we know it as a ligament of arteriosa. The anatomy of PDA morphology, this is just coincides with the what we know from the Krishenko classification, the A, B, and C, and D, and E. But with the advancement and availability of catheter, a new classification has emerged, which called the fetal type, which is our of interest of intervention with this talk. And it constitutes of a significant number, really, even if it is more than 2 kilos in the neonates. But for less than 2 kilos, actually, most 70% of the type of ductuses, especially below 4 weeks of age, is a type F. And usually once they pass that 4 weeks, this tubular structure becomes shortened and shrink. And we will talk about feasibility. From PDA, we know it's a common in the premature babies. Less than 70, if we look at this diagram is basically show us how much remaining of percentage of a prevalence of a PDA on the left-sided Y column, and on the red line here, less than 750 gram baby, almost half of them by 40 days or 50 days will still have a persistence of adductus. So basically what this chart tell us is the younger, the smaller the babies are, the higher risk of having a persistent PDA as a neonate. We know the impact and significance of PDA and neonate. It basically increases the risk of multiple complications they have. It's overperfusion of the lung and underperfusion of the systemic circulation. That will increase the chance of necrotizing colitis, bronchopulmonary dysplasia, pulmonary hypertension, retinopathy, and including even intraventricular bleeding and renal impairment. With the high pressure and pulsatile of the systolic flow through the ductus, through the pulmonary artery, which is underdeveloped in these neonates, they just cause overcirculation. That will cause more of a capillary and pulmonary edema because of the underdeveloped of the thin wall, protein leak, surfactant dysfunction, worsening of lung disease and bronchopulmonary dysplasia, a vascular muscle perforation, and that will lead subsequently to pulmonary and arterial hypertension and overcirculation. And this is a circle that has been already described, and eventually, unfortunately, in middle, this is a normal homogeneous plush face of the pulmonary capillary bed. Then this is basically a naked tree that we see it with a significant pulmonary hypertension that these neonates may develop if it is persistent and if it become high flow and high pressure. So whether it's an evidence-based or physiological application, physician decision our decision making is a complex, influenced by many factors. The factors that support the PDA closure, the physiological benefit, as I described with the adverse outcome from these, whether we have a safe FDA-approved device that does not require thoracotomy, no post-ligation syndrome, and reduce the pulmonary flooding and ductal steal and all the consequences that I mentioned. The factors that against device occlusion, of course, the evidence-based guidelines are lacking. We don't have that double-blind studies. Cost and expense and expertise are needed for such an intervention. Transportation, anesthesia, intubation, all of these hassle that will occur while an attempted to do the above procedure. And long-term benefits has not yet shown. The treatment option we have for these kind of newborns and low birth and extremely new low birth, whether it's a medical therapy, a surgical ligation, observation, or a transcatheter closure. We have, the medical therapy is basically an non-invasive. Unfortunately, it takes days to weeks compared to the immediate effect from a surgical or a catheter. Not effective in 100%, though if you compare to the surgical or catheter is 100% effective. Side effects, complication from a medication, up to 20%. Post-ligation syndrome doesn't occur. And it's only have a clinical assessment when you do medical therapy, whether there is an improvement. It may not resolve it completely, but you will just rely mainly on your clinical assessment with a lot of bias. Surgical ligation has a lot of problems with post-surgical syndrome, and you cannot assess hemodynamics. But the tipping point for the catheter closure, it comes in with the post-ligation syndrome is less frequent. And also you can, at that time in the cath, you can also assess the hemodynamic assessment. So cath occlusion is less invasive than surgery and more effective than medical therapy. Shortcoming of the pharmacological therapy, it takes multiple doses, it's impairment, it affects the lung, unfortunately the adverse effect of these medication on renal, oliguria, renal function, proteinuria, hyperkalemia, cerebral white matter damage that has been reported, impairment of cerebral perfusion, neck, platelet dysfunction, pulmonary hypertension, and hyperbilirubinemia. I'm trying to tackle some of the issues that our attendants from our neonatologists, they may face with these medications. So I try to elude some of these problems I described before. So the clinical dilemma from our cardiologist point of view, a significant PDA in a preemie baby is of no use or good, so closure by whatever. That's sort of like our notion on knee reflex to these kind of issues. The evidence base to close resulting in a shorter, we have an evidence that it will less aggressive ventilation and thus protecting. Some neonatologists have taken a view that there is no strong evidence of PDA closure, especially from the 2016, they are trying not to send them. And they are reluctant unless we have this pivotal study, which is undergoing. And some of the neonatologists think that this is actually, we should not do anything about it. It's part of the development of the babies. We should not do it. From our perspective as a cardiologist, the indication of closure or the significance of a PDA goes through multiple process of analysis. By echo, there's a clear sign of heart failure with LV dilatation, LA to aorta ratio more than 1.4, clinical heart failure by chest X-ray and examination, ventilation requirements is increasing, large PDA on echo more than 1.5, considering with these neonates less than 1 kilo, diastolic reversal, trial of medical therapy which failed, and if unsuccessful, closure to be considered. And I'm stressing on the point is before 4 weeks, and I will highlight it later on. And usually when we consider, especially if it is more than 700 grams, and trying to delay it before developing pulmonary hypertension. So going back again to the treatment option that we have the surgical option now. We spoke about the medical, now we're going through the surgical option. We have a problem with the surgical option with all of the risk complication, whether it's a vocal cord dysfunction, impaired neurological outcome. There is reported cases of PVDs worsening, retinopathy worsening, chylothorax is a chance, diaphragmatic problem, bleeding, pneumothorax, cardiorespiratory failure, acute and severe hemodynamic side effects, which is the post-ligation syndrome, falls through that. Worsening of neurodevelopment outcome has been reported after when you compare medical versus surgical. And also there is also the problem also of residual sun, since this surgical is just a ligation, not a ligation and division, considering with these small babies. So there are many studies, SAM and the others group in the US has led the transcatheter project and the FDA approval of such a device. So from his study that I alluded in the slide before, the transcatheter closure versus surgical ligation showed the demographic. Here is just a snapshot of a picture of the demographic between transcatheter closure and the surgical ligation. There is not much really difference between them. But when you look at the outcome after, whether it's a catheter or surgical, changes in the respiratory score, the time to baseline to return, the time to extubation, all these shows a significant p-value between the surgical and the transcatheter closure supporting that. So now, this is a paper came just last week in the Journal of American Heart Association, where is the trend outcome of surgical versus transcatheter. There is a studies that has been conducted between 2016 and 2020, where there is a lot more than 1,000 and 2,000 patients has been reviewed. And looking at the surgical procedure, the light gray, transcatheter procedure in the dark gray, if you look at between 2016 to 2020, the procedures of the surgical is actually getting less and less and less, with more push to cardiac catheterization closure, especially when you look at them more of a years, especially when you look at the neonates and infant less than 1 year, it's becoming less and less and almost absent from a % of cases. And going in depth with this paper, the outcome following transcatheter, looking at the mechanical ventilation, and duration of postoperative hospital stay and postoperative length, all are suggestive in favor of surgical, of a transcatheter closure compared to a surgical ligation. Not only that, cost, which is the driving force of many of innovation and care, the cost also in favor of transcatheter closure. Going back to a Philip paper with the hemodynamic consequences of early and delayed closure, this is the one I was telling you about, closing it before reaching 4 weeks versus later on. So if you looked at 3 groups, they look at group 1, which is less than 4 weeks of age and in a newborn, and a group between 4 and 8 weeks, and a group between 8 weeks. Group 2 is not of a significant, but if you look at the differences between group 1 and group 3 is remarkable. The procedural age and weight is, of course, is different between the 2 groups. But if you look at this Kaplan-Meier curve, I'll try to explain it to you. So the patient, when you have an improvement into their RSS score, dramatic improvement within the time of PDA closure on the axis, x-axis, it does tell you with this blue dots, which is basically the group less than 4 weeks. So the group that got a PDA ligation, their return or persistence, return to a lower RSS is faster compared to the group which is older than 8 weeks. So that's what I meant in favorism of trying to get these patients before reaching 4 weeks of age, where is the change and the damage happen. Not only that, this is the same thing I was talking to you about in the Kaplan-Meier diagram. So the catheter closure more than 8 weeks is actually a poor predictor of not a great outcome. The potential of even growth and weight gain is actually remarkable between group 1 and group 3. When they are closed before reaching 4 weeks of age, their growth is actually, and the weight gain is actually remarkably statistically different. So going to the catheter closure and what kind of optimal device that we would like to, or the characteristic of that device. We would like it to be a low profile, a 4 French or less. A microcatheter would be great with compatibility to it. Flexible delivery system does not affect your blood pressure, does not have a significant hemodynamic instability, does not affect tricuspid valve, and has an accuracy of device deployment. We would like to have it a resheathable, reliable detachment property, retrievable, ideally would be through the same system, so you don't have to waste your time or changing. Fluoroscopy visibility, and we will talk about more detail when we go over the different devices that is available in the market with these characteristics and differences between them. In addition to echocardiographic sonographic visibility. Echocardiography in this procedure is actually a mandatory and a very important tool in the procedure and the closure. Short device length is important, so you would like to have the intraductal deployment rather than protruding into the aorta or the PDAs. So currently the available devices, the microvascular plug by Medtronic, I will talk about it in detail a little bit, the Piccola by Abbott, and the microplug by Kurt and Platzer group or company. The MVP, or the microvascular plug made by Medtronic, it's actually a microcatheter. It is a very small catheter system. It goes into a microcatheter delivery system, a 3 French system. It covers by a PFT material, except the distal part. The distal 3 millimeter is not covered. It's over 0.18 nitinol pusher wire. And basically control the delivery and resheathable and retractable, and has been FDA approved from August 2013 for peripheral embolization. And from our perspective, we utilize that one in the PDA subsequently. It comes in many sizes, but mainly the one used for the neonatal PDA is basically the MVP 5Q, which is basically the target diameter vessel is between 3 and 5 millimeters, which is the commonest size that we're going to face in these preemie PDAs. One important factor you have to understand: the unconstrained device length. It's up to 12 millimeters. So remember, this is a long device, and I'll show you a challenging case that I did from my experience. Maximum device when it's constrained is 15.3, and the diameter of unconstrained is about 6.5 for a defect, which is 3 to 5 millimeter. This goes into a 3 French system, but when you go to the 7 and 9, you need the 4 French and the 5 French system delivery. It has a less distortion, very flexible delivery, and it does not require a sheath exchange. Unfortunately, the distal and covering, with this mesh covering, unfortunately, you only have 3 or 4 times to be sheathing and unsheathing. Otherwise, this material will be distorted. So you have to be careful. It goes through 3 French system. The distal part, which is an open cell, does not get the cover. It helps us maybe to get away with protrusion into the aorta that will may affect the aortic flow. But with this uncovering, it gives us a chance that maybe a little bit protrusion without any effect. So unfortunately, there is a bit, our drawbacks with this device. You have to understand it's a very lengthy device. We'll show you an example, and it does not form completely at the time of delivery. This is a very important, and I'll show you a live case from my experience. And the PFT, as I mentioned to you 3 times, is important. Just looking at the experiences and how they develop them over the months and years, and the averages between the devices, you can review and look at them. Moving forward with the Piccola, which is the FDA approved PDA occluder for premature baby less than 2 kilos. This is how specific device is. We know it if you go from the catheter. This is actually one of the additional sizes that we use, but they renamed it for a financial and business model, but it is the same almost device. It's a self-expanding, it's a central waist. It comes at, it's advocate from January 2000 for more than 700 grammars, 3 days, when you have 3 millimeter longer, but it does not, it's not recommended for larger than 4 millimeter diameter PDAs, and has been approved with that pivotal trial that included 15 patients. It comes into a total of 9 sizes, 3 waist, 3 length and device. I'm not gonna bother you by a lot, but the most important factor is it when it comes released, remember the disc or the retention disc on both sides is at least 1.45 millimeter bigger than the diameter of the waist. It has, fortunately, a good radio-bake visibility, similar to the other Amplatzer devices that we use. Gate echo visibility, which is very important, especially when you're going to rely on the transthoracic to deploy, because we don't have an arterial sheath in these patients. Shorter length for shorter PDA. We are familiar as an operator with it because it's the Amplatzer family. Easy to use, easy to retrieve, and it's actually one of the fortunates is on label, which is our discussion with the family. Unfortunately, it's a stiffer system, has a lot of problem with blood pressure, so be ready. Reported cases of tricuspid valve injury and may cause LP and arch problem, and does not cover or occlude larger than 4 millimeter. It's risk of embolization. And some of the reported cases looked at also fluoro time compared to the MVP. It takes a lot longer fluoro time to deploy and position this device. Another device, a third one, is the micro plug. It's similar to the device that I showed you from Amplatzer or the Abbott, but it's fortunately that goes into a 3 French system, whether it's a 3 millimeter or 4 millimeter or 5 millimeter. You can deliver it through a 4 French angle glide catheter with the micro catheter, and you can use this as your injection, which is a very excellent, and Huwaida Sayed did the report, and I will share some of her experience. So just to summarize all of these devices, from a low profile, soft, whether resheathable, detachable, retrievable, all of these features, the main thing important is you're going to be differentiating the vascular plug, the micro plug and the Piccolo, almost they are fall in the same territory, and the MVP is the softer one, if you just remember that. And then MVP is usually for a longer PDA use. These ones are for shorter PDAs. And at King Abdulaziz Cardiac Center, when we have one of my colleagues now, he's in Al-Qasim, when he was part of his training here, Yazid Ahmed, we developed our pathway that sort of like to facilitate the referral and facilitate the assessment and have a consistency when we evaluate our PDAs before reaching the cath lab. I will share with you our experience. When I started initially with a 2 kilo units. You see here on the left-sided corner, you see a PDA. very large, significant PDA, dilated LA, and you can see how big is the PDA, almost bigger, if it's not bigger than the LPA and RPA on the right bottom screen. This is the technique. This is a courtesy of Hawaii. What you use, this is the glide catheter, and this is the micro catheter, and this is a 14 wire, and basically you just track it and go all the way through the ductus, and then you can push your system, and then you can use the glide with the Y connector over the wire, and you just do your injection. This is the only injection you're going to need, and most probably it's a lateral projection. Rarely we use the AP, and this is where you get the diameter and the assessment. And basically, if you see the temperature probe, which I encourage and have, I think it's as a must tool for us in the fluoro, is a great landmark where your distal part of the PDA. Looking at this kid 2 kilo, position the device, look well positioned here. This is the aorta, positioned very well here. You see the tip here, the bright tip, and here when you see the branch PAs and you see the bright device sitting into the body of the ductuses. Here again, 6 months later, this is the same patient. You can see the LPA, a little bit mild turbulence, but when you go high up a little bit, the bifurcation of the PA in the bottom screen look very nicely wide patent, and no evidence of any significant mitral or tricuspid valve regurgitation. So I moved and pushed the envelope a little bit further to 1.4 kilo. You see how this is a big device. It's big PDA. It's very long PDA, so this is more of a MVP material. You see the branch PAs. Looking at the dilated PA, no coarctation in this patient. You have to have a baseline assessment of tricuspid valve and tricuspid regurgitation before and after positioning. This is again looking at this, as I mentioned, it's a long tubular ductus. This is usually the fetal type. And this is when you see the device sitting. Unfortunately, MVP, as I mentioned to you, not as the other devices, fluoro or echo is not the greatest, to be honest with you. So you have to have your echocardiographer familiar with, and you see how sort of like not that great appearance by echo or fluoro. Here, later on, you see it very visible here. Arch is wide open and branch PAs look open. There is maybe a whiff of regurgitation here at the beginning, but 6 months later, good sized branch PAs with no residual problem. Tough case. I would like to, one of the last, live cases that I've done. I'll share with you. This is I entered the sub 1 kilo territory. You start to see the LA is so huge, dilated, the ratio is big. You see the PDA is how big it is as maybe larger than the LPA. Assessment of the TR, there is mild TR, mild MR, baseline. Looking at it, the ductus is not, I don't know if it is long or short. I underestimated, I thought it's long. So you see, this is the MVP coming into for positioning. You see it's coming all the way into the glide for positioning. I put it in, it's a little bit elongated, underestimated. This is where the pulmonary valve here, where you see my black arrow. Here in the echo, does not look bad. So the LPA, a little bit mild narrowing, mild residual leak here. I thought it will be okay. Discussed it with my echo colleague, who said okay. So next day, you look at it, arch is good, little bit protrusion more, mild LPA stenosis, but 2 days later, even elongated. This is what I was telling you about the MVP. The problem is it does reshape itself or retake itself the shelf in a day or two. It does not form completely the way that you want it. So this is now the device is a little bit more protruding, more LPA stenosis, a significant LPA stenosis. So I had to go back again, engulfed it and retrieved it, reassessed the PDA, still large. So what I did is I used the MVP. You see how the MVP here, very echogenic, very beautiful, seen by echo. You see the rod in the left upper screen, and you see the two big discs that I have in the middle into it, and you see the branch PAs, and you see this is the rod still attached to it. The device is within the ductus, and here you see just a quick angiogram here. You see the LPA is widely open, and you see most of the device is actually plugged inside the ductus itself. This is what we looked for. And this is again looking at it after the arch here on the left screen, and you see where is the device here is very nicely echogenic by echo, and you see the LPA is very nicely wide open with no residual leak and no obstruction. And this is after a couple of weeks before discharge when we did the echo. So tricks for this kind of procedure, I cannot stress more, it's a team approach. Homeostasis is very important when you deal with transportation inside the cath lab and to the cath lab. Early experience, you have to consider having the neonatology team with you inside the cath lab, whether it's the assistant or the fellow with you. Pre-cath huddle, I think I recommend it, even if you are inexperienced. Every time in these kind of patients, you have to come in together as a team and huddle about them. Post-cath briefing is important to see where you have opportunity of improvement. And you can develop a QI check where basically you can put all the lists that I'm talking to you about as a checklist for your nurses. So the core temperature is important, the isolate, the heating labs in the cath lab, the forced ear. You have to make sure your fluids is warmed. So all of the fluids that I use, the flushes, is actually coming from the warmer, like from the blood. When we used it, it's actually, we use the same warmer to warm our fluids, the baby, because they can get easily cold. Remember to clean the gel after from the transthoracic. This is a patient that I did. You see how much of a plastic and a wrapping plastic that I put on the patient just to keep up the temperature. And you can see the warmer, I actually bring them closer and just tape them closer to the patient just to provide enough warmth and controlling the temperature. Glucose is important. Airway, secretions, having the nurse of the baby is important, giving your feedback, CO2 monitoring, and extending tubing. Remember, these are babies, are just maybe a dot in the cath table. So you have to make sure that you have a lot of tubing extended and cable and ECGs to be able, without stretching them out. It's a different, they are different compared to other patients. As I mentioned, the fluids, you have to be careful. I don't heparinize these patients. They have already enough heparin from the heparinization. I do follow up their glucose, their blood pressure, make sure the blood pressure cuff, because we don't have an arterial line in this patient. If they have a UAC, it's great, but most of them will not have an arterial pressure. Make sure the cuff pressure is away from your axis, away from the PICC line axis, and will be easy for the anesthesia and has a good monitoring and reading. Machine placement and minimize stimulation and have a clear, there are special drapes that can give you a clear view of the babies. Some of the things about the stiffness I mentioned to you, if you see that using some of the snare catheters, you see how the curve is smooth. This is the curve that I see with the Piccolo devices. Remember, be careful when you put the device in. This is a catheter. When you put an injection, look how the tip, this is, I always tell my fellows, even with ASD, make sure that these kind of catheters, when they snap back, and you do the injection, it's almost outside the vessel. So you have to be careful. And also remember, these catheters can carry a clot, and a clot burden with these patients is very significant and dangerous considering their weight and the small caliber of vessels they have. So in conclusion, catheter occlusion is feasible for these patients, and I think it's safe in a tertiary cardiac center and well-established experienced personnel. It is a defined therapy. Unlike the pharmacological therapy, unlike surgical, no scar, no stitches, marks. It may be beneficial to include PDA before 4 weeks, and I think more studies are coming out to support that. Early occlusion may also afford a faster weaning of ventilator, and of course the cost and the oxygen. It requires a team approach and planning, and I can't stress that even more and more. Not only from the NICU, but also within the cath team. Attention to cath lab, to catheter manipulation, stiffness, blood pressure, tricuspid valve injury, and your colleague from echo assessment. You have to build a good rapport and building an experience with them. It's not having just an experienced catheter echo sonographer with you, a consultant, but also having their experience to be able to visualize these catheter equipment that does what and understand what does it mean to be inside the PDA and protruding or not. And I appreciate you and thank you very much.
Thank you, Dr. Ahmed. Thank you for this nice presentation. Really, we enjoyed. Most of us, I think, some of us maybe the first time they hear this talk, but some of us has heard it from here and there. I was in BICS, I think around 2012, and Neil Wilson talking about coil closure of the preemie baby with ultrasound guided or echo guided that time. And the people, and most of the people, they said it's very difficult. And the minute you lose its coil, it's very difficult to retrieve, especially in small baby. Sure. I congratulate you, Dr. Ahmed, and your cardiac center, King Abdulaziz Medical City, for this huge and innovative procedures, which is really will change a lot of things, especially the concern of the neonatologist regarding the post surgical syndromes, which is really most of them they change to be a conservative rather than to do anything because of this syndrome, which is really very sick. I attend few conferences or meeting from this neonatologist neonatal cardiovascular, and really this is a major issue for most of them. We have few questions, and still also waiting for the other people to come with the questions from Dr. Nabil. He's asking, Nabil Abdulrazak from Eastern Province. He's asking, what is the lowest weight you can deal with, Dr. Ahmed?
Well, I mean, the recommendation, I mean, we go with the recommendation and the devices. I think if we're going to go with the current standard of care, 700 gram and bigger is the current advised way of going and tackling these. There are cases that, you know, you see it in your practice where they are preemie, they stuck around 650, 620, and they are already reaching 4 weeks, and they may need a PDA, whether it's a surgical or cath. I do believe having a cooperation and collaborative work within ICU is important. So as Dr. Umar mentioned, some of the neonatologists think this is a PDA, is part of their disease. Don't interfere, don't play with it, don't hassle with it, just leave it. And I do believe that need to be changed, considering if we have a safe alternative, less invasive. And I think by the time, you know, evolve, I think we're going to reach a time that there will be no, you cannot do a PDA before a certain time of age, and you can do a PDA afterward. And you don't want to delay it later on, similar to, you know, other congenital heart disease that we have. You know, there are certain lesions that you will not be closing or dealing with because it's too late. And also you cannot be interfering with lesions that are too early. So I think there will be a setup of early, but I think before 4 weeks, we need to think about it, especially when you're beyond the 3rd week. And if there is a patient who's going into a big, massive heart failure because of the PDA, to really think about closing it at that time, because this is where the maximum benefit you're going to have. And the good window of the ductus. The ductus itself, it's actually tubular. The longer that you wait, not only just the patient condition on the lungs, but also the ductus shrinks. So it's going to be more harder for the choices of devices you have.
We have also another question from Dr. Saud Bahaydara. We have 2 questions from Dr. Saud Bahaydara. He was the procedure after the failure of therapy or medical therapy means? The medical therapy, you means you give him a trial of medical therapy, doesn't work, you will take him to the cath lab, or you will take him without it?
No, Dr. Naif, remember, I am not referring these patients to me. They are not in my unit. So what I'm relying mainly on our neonatologist. Maybe Dr. Umar knows, but me and Ahmed bin Ahmed Yazid, we had to meet with our neonatologist many times. We did 2 presentations, like a mini grand round presentation for the neonatology team about PDA, benefit of closure, just to try to convince them in accepting the idea of having a cath closure and bring them early on. I do believe they're going to use medical management, but at least if it is failed and you give it maybe a 10 days, you know, as I described in one of my slides, a 10 days period after the medical therapy, hoping that before reaching the 4 week of age, and then you will be able to assess again and look at it. I think by medical therapy, you will know by the day 4 or 5, if the PDA is same as before, that will not affect or will not have a benefit. So you will start to plan yourself ahead to go ahead and plan for it to be closed.
I have the same question from Dr. Saud Bahaydar again. He asking how Or was the neonatologist resistant toward this such a new procedure?
Well, I mean, it's a human nature. I mean, if you look at them and looking at their experience with the surgical, as you mentioned, Dr. Ahmed Alomrani, with the post, you heard a lot about it, and I heard it from my team, is the post-surgical syndrome. When they go, they actually don't send them until they are really, really struggling, and when they go and do it, they expecting that they're gonna go through a couple of days of post-surgical. And it's up to 40%. So it's not something simple. So I think them seeing me doing these PDAs, going in and, I had this bump with that patient, as I told you, the sub 1 kilogram, which is I had to retrieve. But looking at it again and looking at me that I'm doing round on the baby twice a day, coming in the weekend and looking at him, looking at the groin, they felt more comfortable about them because they're going to be recovering back to the ICU. They're not going to stay in my cardiac ICU. So that helped in alleviating that stress and ease it in a way. And I'm just telling you that if there are now centers where they're actually purchasing a C-arm, mobile C-arm for their NICU unit, not just for the cath, but for other intervention. And one of my catheterizer colleagues in California, they're actually using it to do it at the bedside. So they just need that injection and they're going to utilize all echo based. So they just do the fluoro quickly to assess where crossing and the quick angio if needed. And sometimes they skip it if they have good echo views and they just close it by echo. So they are pushing even a lot of my colleagues in, this is a center they put because they have this mobile unit purchased. And it's going to be, a plus if any of my colleagues here are going to have a new hospital. It would be nice to, get them that mobile unit. It's not going to be just for you, but it's for other procedure, but you will be able to use it to do it at bedside for NICU patients.
Great. We have another question from Dr. Naif Fashi, who is asking for how many courses of medical therapy you tried first?
Well, I would usually leave it to the NICU team. I usually, you remember that some of them will favor ibuprofen, some of them will have favor paracetamol. Each unit has different. So each unit has own different pathways of these medical therapy, and then they will declare them as failed. So I don't usually interfere with their pathway in regard to how many courses they should use before.
Dr. Mati also asking, how about the other type? You know that the fetal type is the commonest type, but what about the other type? If you face with the other type, are you going to close it?
Yeah, I mean, we close them all, but remember, when you do that, you have to consider the anatomical feature and where you're going to put the device and how you're going to be delivering it. And you have to make sure your echo colleague understand what you're talking about and the shape of the PDA, because their position and the way it's going to be positioned by echo is going to be different from the tubular. The tubular, he will know that you need to center it or put it inside that tube. But in the cone shape, you may be going to have a little bit protrude of one of the discs into the MPA, but most of your disc, because it's a 3 constrained disc that's going to be delivered. So maybe 2 of them are going to be into that ampulla, and part of it going to be one of the, especially the buccula, going to be into that MPA side, especially when you're considering the conal shape, which is the second commonest type. But other ones, I didn't show. I showed you briefly one of the, summary of the preemie neonates is actually they did actually coil. So they did one of the studies. They did actually share their experience is basically a coil in one of the patients. So it's not like unheard of that you don't use coil, but I do believe you have to understand the anatomy and have the appropriate equipment for it, and your echo staff help you with that.
Dr. Ahmed Alomrani asking which axis you are using, the femoral or umbilical?
If I have umbilical, it would be great, but most of these patients will have a PICC line through that umbilical or some line, so I don't usually want to waste it for the NICU. The cases that I've done, all of them are femoral with ultrasound guidance to get the access.
Great. Dr. Khalid Al-Umran, he asking from the real life, what is the complication that can happen and is it common?
No, the complication, as I mentioned, in this slide, if you look at it, they in the initial experience they reported it from the groups, different group and different. They do have some of the reported, but from the last experience that just if you look at the Piccolo website by the company, is actually so far from their follow-up studies, they are now up to 300, 0 mortality. So that is great. I mean, you're looking at it, a baby who is getting a PDA with no mortality is an excellent procedure. So, I mean, and you get, considering the cost effectiveness also you put in that, you're just basically saving a lot to these patients. So I think you know, the complication is there, but if you look at it, it's mainly anatomical complication for PA obstruction that can be dealt with, and most of the studies that did not require surgical, except if they are embolized, and that was one of the 8 patients that Hawaii reported. That was their an early experience in 2016, but after that they did not have any embolization.
Great, Dr. Ahmed. Really, it was a nice night and great presentation.
Thank you very much. I appreciate it.
Great subject. Really, we touched something new for most of us. And really, I hope our neonatologist can have more convincing to refer the patient, because the other choice is getting better and better than surgical choice. And we'll continue with this continuous medical educations for everybody.
Thank you.
Thank you for everybody. And if you have no questions, we will leave and close the meeting.
Thank you very much. Thank you. Thank you, everybody.
Thank you very much.
Thank you.
Thank you, everybody. Thank you. And see you, inshallah, in the next month. We'll have another subject and another presentation. Thank you.